I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello and welcome again, everyone, to the February edition of this year's Journal Club. We're very excited to have Dr. Cederna here with us, moderating our discussion. Welcome, Dr. Cederna.
Thank you very much. It's my pleasure to be here.
We also have Sammy, Sinno from NYU, and Amanda Silva from the University of Chicago joining us as our resident ambassadors. And for this next section here, we're going to discuss an article out of the Fox Chase Cancer Center by Drs. Chang et al. On looking at the long-term operative outcomes of preoperative CT-guided virtual surgical planning for osteocutaneous free-flap mandible reconstruction. As a corollary to this article, which we'll get into in a minute, we also have free online at prsjournal.com a CME article on overall head and neck reconstruction, an article by Sinno et al. On the important aspects of head and neck reconstruction. And then two recent journal articles looking specifically at virtual surgical planning. One is virtual surgical planning in complex composite maxillofacial reconstruction by Sawh et al. From 2013, and the other is the functional outcomes of virtually planned prefibula flap reconstruction of the mandible by Avram Tomer et al. And that's coming out of 2014, and both of those describe aspects of virtual surgical planning, the pros, cons, and their respective centers' operative experience. For this month, we were looking at, again, this article from Fox Chase Cancer Center, where they looked at over 11 years, retrospectively, of all their free-flap mandible reconstructions at their single cancer center. And they looked at the value of CT-guided virtual surgical planned outcomes and the efficiency of mandibular reconstruction for osteocutaneous free-flap. They had 92 patients that underwent flap reconstruction this time, and of those, they broke them down into patients that had virtual surgical planning versus those that did not. And they looked at multiple series of outcomes, including revision rates, need for bone grafting, bony unions, and their operative time. It's actually one of the largest series of virtually surgically planned free flap reconstruction, and they actually looked at a fair amount of outcomes that I think haven't really been looked at in this amount of detail over this long of a period. The majority of the cases were patients who had squamous cell carcinoma, like the majority of head and neck cancers end up being, and they demonstrated that they had a much higher result of accurate osteotomies. They used cutting guides when they did virtual surgical planning. They noted that the mandible opposition in their group had a lower gap rate, it was 1.3 millimeters versus 1.6 millimeters. They had an increased accuracy in their leading to decreased operative times and decreased ischemia times, and they have very specific numbers: 666 minutes of operative time versus 545 when they did not use the virtual surgical plan. And their ischemia times were also less. That was actually significantly cut down from 120 minutes to 73 minutes. And from these, they say that there will be a cost savings relative to the operative times, although there's not a lot of specific cost data, or we don't really get into the discussion in this paper about how much it costs to make these plates using the extra added time of planning ahead of time and then the cost of the custom plates. However, I think just ultimately wrapping up the review of this paper, they really show in a long-term series an overall additive benefit of virtually surgically planning, making it easier to use in the operating room, being able to use custom guided plates, using custom guided cutting guides to create better opposition of the bone, faster operative times, and improved outcomes overall as it relates to cost by reducing this time. So I think this really adds a significant amount of data to sort of a growing trend in free flap reconstruction. And I think one of the things I think Dr. Cederna was with us last year, and we'd had a discussion already on virtual surgical planning, as it generally seems to sort of be an obvious thought that you'd want to have very accurate CT-guided planning for this reconstruction. And I think this is starting to really add some meat to that data. I know there's a lot of literature out there in sort of smaller case series, but I think it's the first time we're seeing such a robust amount of patients being evaluated for both of these groups.
Yeah, so that's a really nice review of the paper. Well done. There's no question about it. If I hired a carpenter to come in my house and he was going to put crown molding in and he just starts hand cutting all the wood, I'm hiring someone else because that's going to be sloppy. And I got to tell you, people have gotten pretty good at putting these cuts on the fibula to get things to bend the way they want and match the way they want, and they close gaps and things, and they've done very well. But it just makes sense that we use the technology that we have at our hands to provide us with cutting guides and preoperative modeling of everything to just make it easier. So is it easier? I have no doubt it's easier. Do they close the gaps when they do their osteotomies better and they're a tighter fit? Absolutely. Do they probably heal better? Absolutely. Does this study tell me all of that without question? I'm not exactly sure about that. Great study, huge numbers, but when you take any study and you start looking at all the subtleties and all the confounding variables and everything, you need huge studies to answer the questions unequivocally. But still, it's a great study. The results say exactly what I would expect them to say. But if we were going to consider the confounding variables, what are some of the confounding variables that could impact the potential outcomes that they measured? What kinds of things in these patients, both locally and globally, might have an impact on it?
Yeah, absolutely. I think two big things come to mind. One is certainly the need for wider resections or being able to plan the amount of resection that comes up. So usually for smaller cancers or areas where we know that the resection of bone will be pretty much fit within the cutting guides that you could have, that makes for an easier operation in essence. Oftentimes, and they discuss part of this in the discussion where if you do need to sort of off the cuff burr down more bone or change the operative plan based on that, then that can slow you down and add differing factors into this data here. I think that the patient disease and degree of difficulty of the vasculature will confound the operative times, for example. So the microsurgical aspects of it and complications from that, which they also look at, but those are sort of two separate aspects of the complication and operative time with these patients. There's also a retrospective review, which certainly has its own limits. There's a learning curve for use with the virtual surgical planning. And then if you have a mixed faculty, some senior authors or senior surgeons are very comfortable and do osteotomies, sort of off the cuff and are resistant to use this because they've had excellent results over longer periods of time. So I think some of those things do make for a bit of a muddier data. But I'm not sure if there's other thoughts you had, Dr. Cederna.
No, I think you're right on the money with that. It's quite clear that when you're looking at it retrospectively, there's a selection bias. Certain surgeons like some technique versus another technique, so certainly that's a situation. 13 of the patients had osteoradial-necrosis, and obviously in those cases that creates a much more challenging situation of getting a bony union. And so if more patients with osteoradial-necrosis were in one group versus another, that could skew the data one way or another. There's, 7 of them, so almost, not quite 10% of them had fistulas and needed reoperations. I mean, this is the nature of the beast for these operations. It happens. But, was there something about the way the bone was manipulated with one technique versus the other that may have impacted the soft tissues or the viability of the soft tissues in some way, and that's why there were more fistulas? And you don't really know the answer to that question either. However, I mean, despite all of those things, as I look at their study and as I read the results, I believe every bit of it. It all makes sense to me. Intuitively, it makes sense. And I certainly believe it, despite all of the shortcomings that really come with these retrospective studies and selection bias and a lot of confounders.
What are they doing in Michigan, Dr. Cederna, if they're doing fibulas? Are they modeling most of them, or is it a surgeon preference?
Modeling them now, and I will tell you from a time standpoint, when they were first being done with modeling, it took way longer, because there's just a lot of stuff And there's,
Right.
just getting everything right and doing things in the right order and using the right guide at the right time. And so there's a lot of things. But then as that process gets more efficient, it obviously speeds it up dramatically. And then when the people in the room, the scrub techs and the circulators know what's going on, and the surgeons know what's going on, and the residents and the fellows know what's going on, it gets really fast and much faster than in the old days.
Right. I think there's no doubt that this is state-of-the-art, so it's amazing.
Yeah. Dr. Cederna, I'd be curious what you think. They mention how they use it now in all of their cases, but in more simple, straightforward mandible reconstructions where it's just a segment, maybe that you aren't going to do a lot of osteotomies, do you think that there's still value in using the virtual surgical planning, or do you think in these more straightforward cases you should pre-select whether you think it's appropriate to use virtual surgical planning or not?
Yeah, I think that's a great question. And, for some surgeons, every single case, they'd probably like to have it so they get the cuts on the end just the way they want them. For most surgeons, though, particularly for the easier defects, where they're going to need fewer cuts, not spending the money to get this all set up and not spending the time and all the extra effort to get it set up, it's probably unnecessary. Mm-hmm. But somewhere in the road, there's going to be a sweet spot. And so like any new technology, it comes in, we learn how to use it, we use it for everything, and then in the coming years, as we use it, we figure out what it's good for and what it isn't as good for, and then the pendulum swings back a little bit and finds the center relatively quickly.
Mm-hmm.
Yeah, this is great, guys. Well, thank you so much for everyone's comments, and we'll move on to our next article.
Okay.